Okay. Welcome for everybody. Thank you very much, Roy, to organize this Cavernous sinus webinar under EANS skill-based section. The first talk is Sébastien Frolich. I don't know if he's already here or no. Unfortunately, Pierre Grosch, he cannot attend this meeting. So I propose to start with Ori Schroeder. Harry?
The screen is empty. So maybe I can start me.
Yeah, go ahead.
So I will share my screen. Everybody see my screen or not?
Yes.
That's good.
If you could just play the slideshow, that would be better.
No, because it's not the good screen. Okay. Okay, so I will. Because I need to share. I don't know exactly how.
We see your screen already. You can just play the slideshow, and that will be enough.
That's fine here.
Not yet.
Oh. No, that's. That's fine.
No, it's still, we cannot see now your presentation at all. Perhaps you can unshare and share the screen again.
Okay. Because I have two screens, so sometimes that's okay. So okay, let me see. That's good?
Yes, perfect.
Okay, so we can start. So my talk was focused on the role and the indication for pituitary surgery to go inside the cavernous sinus, so which is quite controversial. So we were supposed to have a talk about the anatomy, so I have only a few slides on the anatomy. You all know that the pituitary fossa is in between the two cavernous sinus, and it's quite narrow space. I really like this anatomical preparation from the Laboratory of Anatomy of Tours in France. You have here the pituitary fossa, the pituitary gland, and the pituitary gland inside the dural bag. The dural bag was slightly open up. You can see here on both sides the cavernous sinus, and you can see here that the medial wall of the cavernous sinus is a very teeny structure. You have the tuberculum of the sella, and you have here the cavernous sinus ICA. You can see here the inferior hypophyseal artery. So it's very quite narrow space, the pituitary fossa, in between the cavernous sinus. You can see here in his histological coronal slides that there is the pituitary gland I really also like this slide because that show you the very close relationship between the pituitary gland and the cavernous sinus, with the carotid, with the third oculomotor nerve, the third is here. We have the fourth, the sixth, and the V1. And we are here inside the sphenoid sinus. So everybody know the anatomical publications of Roton, very quite famous anatomist, and we are here inside the pituitary, the temporal fossa. The cavernous sinus is right there, just a triangular shape between the pituitary fossa and the temporal fossa. And there is the loop of the ICA, the optic nerve. We have the third nerve, the fourth, the sixth, and the V1. So very quite narrow space with a very rich environment of nerve and vessels. So during my residency, the first message, because I start my residency at the end of the golden age of the school base. And my former boss was Marc Sindou, who performed a lot of pituitary, a lot of cavernous sinus surgery, especially for meningioma. And at the end, the message, because we have more and more option to treat the patient, especially modern radiotherapy, the message was the paracellar space was a surgical lumen lens, especially for pituitary. So the cranial route is the usual route to approach the cavernous sinus. You are here a subtemporal extradural approach. Here is the operative view. We have the temporal lobe here, pushing away a little bit up. We are in the pituitary, in the temporal fossa, sorry, and we have the V2, the foramen longitudinal, the V3, and we have the temporal lobe. The petrous bone is right there. And if we lift up a little bit more the temporal lobe, we will have a lateral access to the cavernous sinus. Here is the cavernous sinus on the lateral aspects. And we have here the third nerve that's entered the cavernous sinus on this roof, the fourth nerve. The sixth on the dural canals should be right there. And we have the trigeminal branches, not exactly inside the cavernous sinus. Here is the medial cave. We have only the V1. The V2 and the V3 are over there. So it was the regular surgical approach to the cavernous sinus. Now you know that, especially with the endoscopic technique, there is another route to approach the cavernous sinus. It's the nasal approach with the endonasal approach with the endoscopic straight and angle endoscope. You get inside the sphenoid sinus. We are inside the sphenoid sinus over there. The pituitary gland is over there, the pituitary fossa, the clival recess. There is the optic nerve. There is the C5 portion of the ICA, paraclinoid portion of the ICA. Here is the lateral opticocarotid recess. And if we move more laterally, you have the supraorbital fissure over there, the orbital apex here. The cavernous sinus is just here. You have the entry point to the medial cave just below and more lateral to the cavernous sinus. And we have the paraclival segment of the ICA and the petrous bone. So when you look at this MRI, you can clearly understand that the endonasal approach, moving more laterally than the pituitary fossa, it's a very good option to remove some kind of tumor. So there is still some indications. If we are not talking about pituitary adenoma, we will talking about pituitary surgery later on. There is still some indication to remove a tumor inside the cavernous sinus. Like in this case, it was a huge neurinoma. with a pituitary deficiency. There is no oculomotor nerve palsy, so we expect the oculomotor nerve was lateral at the level of the lateral wall of the cavernous sinus. So we use the pituitary fossa, and we use also transcavernous sinus laterally to the carotid to remove it was a subtotal removal, and we stopped the surgery when the oculomotor nerve monitoring started ringing, and we send the patient to the radiologist, to the radiotherapist, sorry. So there is some indication, like in this case, a huge tumor invading the paracellar space, and we remove as much as possible coming from below. It not a pituitary, it was a chondrosarcoma, that it was the result after the endonasal route. So there is still indication to operate inside the cavernous sinus, depending on the tumor. For sure, if you start to deal with this kind of surgery, you need the cranial nerve monitoring, and you need also to check the functionality of the Willis polygon in case you have a vascular injury. So now we will focus on pituitary surgery because it's a controversial topic, cavernous sinus surgery for PITNET. It's a long journey for pituitary surgery, starting for the first case of William Horsley in the beginning of the 19th centuries. The 20th century, sorry, he operated on the first case published of pituitary surgery. It was subfrontal approach at that point. At that time, it was a great success because the patients survived 2 weeks. You all know after the development of the transsphenoidal routes and the Cushing in the US in the 30s start using this kind of approach. And you all know Cushing because he described the disease that's where his name. So he gave up with the transsphenoidal route, and only very few surgeons continue to use this endonasal route to reach the pituitary fossa. And it was the case of the normal bed in Edinburgh, and in France, the transsphenoidal route get back with Gerard Griot from France. And after, there was a new progress at the beginning of the 1980 with the introduction of the endoscope. So you all know now that since it's not new because it's 2 or 3 decades ago, with the Naples team, Italian teams, and the Bologna team in Italy and the Pittsburgh team, we use now more and more the endoscopic approach. Because it's very useful for a huge pituitary adenoma, for extended approach, paracellar approach, transtubercular approach. For regular pituitary case, knobs, we will see knobs, the tumor which are strictly on the midline, inside the cellar or inside the cellar or extending beyond in the supracellar space. The microscope is good as well at the endoscope. But as soon as you start moving more laterally, you extend the approach, the endoscope is far more better. So what is the anatomy when you use the endonasal route for pituitary and for paracellar locations? So you are here inside the pituitary, the sphenoid sinus. We have the pituitary fossa. There is small area when there is no tumor. And you can see here the cavernous sinus with the loop of the ACA, the medial wall of the cavernous sinus. And laterally to the ACA, you have the lateral wall of the cavernous sinus with the oculomotor nerve. The third one is over there, the fourth, the sixth, and the V1. So to approach the cavernous sinus using the endonasal routes, there is 2 routes you can use, the medial approach you are walking lateral, you use the pituitary fossa, you can get inside the cavernous sinus using this medial approach. But the more difficult surgery and the more aggressive approach, and when you start operate through a lateral approach, when you start walking laterally to the ICA. So what's about PITNET? PITNET is a new name for pituitary adenoma. You have to think that the PITNET are benign tumor. So the first question is, shall we do aggressive surgery, perform aggressive surgery for PITNET? There is many now literature about that. The pituitary PITNET are benign tumor, but they are often invasive tumor. 1/3 of the tumor invade either the sphenoid sinus or the cavernous sinus. That's like in this case. So we have to deal with benign tumor which are invasive, and the treatment, the surgical treatment, have to cure the patients, and sometimes it's very difficult. So when there is invasion of, like in this case, of the acromegalic patients, there is very often in acromegalic patient an inferior extension. So you have the pituitary fossa over there. There is clival invasions, dural invasions at the inferior part. So it's not so difficult. You have to drill, like in this case, we drill the clivus, the invade clivus. We remove and we remove the inferior part of the dural bag, like in this case. Here is the pituitary gland. Here is the medial wall of the cavernous sinus. So when there is inferior invasion, it's not a big deal. The difficulties start when there is cavernous sinus invasions. So you all know the classification of Knopf, and there is a modified classification in 2015. The invasions start to be elevated when it's a grade 3 Knopf tumor. That's mean, and there is two kind of grade 3. There is a tumor that's extend in between the two carotid loop. It's a 3A, so it start to be invasive at 3E, but the more invasive tumor is grade 3B. That's when the tumor extend inferiorly to the cavernous sinus, inferiorly to the ICA. So 3E, sometimes it's not in invasion, it's only the tumor pushing away laterally the medial wall of the cavernous sinus, and the tumor grade 3B start to be very invasive, close to 70%. And for invasive tumor, all the grade 4, that means tumor surrounding the carotid inside the cavernous sinus, are invasive tumor. So we use it's very easy and very useful classification, but sometimes it's not so accurate because it meets some coronal, some axial view. Sometimes when you look only on coronal, on midline, you can miss some posterior invasion inside the cavernous sinus, but it's another story. So why be more aggressive for PITNET? For non-secreting pituitary adenoma, that means gonadotroph adenoma are more or less slowly tumor, very benign. So the goal of the treatment or the surgical treatment is to reduce, to decompress the optic apparatus and to reduce the tumor as much as possible. And in many cases, there is a small invasion inside the cavernous sinus, and there is no real benefit to make an aggressive surgery for this kind of tumor. It's not the same story for secreting pituitary adenoma because like in this case, secreting pituitary adenoma, it's acromegalic patient in this case. There is a cavernous sinus invasions. You can have some corticotroph adenoma. It's not the same story for prolactinoma because we have a very efficient medical treatment. But for the first case of secreting acromegalic and corticotroph, only surgery can rapidly cure the patient. And sometimes it's very important not to let the patients with the disease for years. There is no curative drugs. I mean, when you start medical treatment, it's not curative, it's only decreasing the size of the tumor, normalizing the hypersecretions. But when you stop the medical treatment, the disease starts again. And the radiotherapy technique we can use take times. Sometimes there is resistant to therapy. It's not so frequent, but in many cases it's not a resistant to therapy. It's only because the tumor is acting very slowly, and it's very expensive. And also the last results we can advocate, it's when you have medical treatment or radiotherapy, especially for secreting pituitary adenoma, the treatments work better in smaller target. Like in this case, we decide not first to operate the patient because there is an invasion of the cavernous sinus. 1 year after the patient was not controlled, they put analog of somatostatin. The EGF-1 level was still elevated, so we decide to operate the patients to get inside the cavernous sinus. The patient was not cured, but 1 month after surgery with the medical treatment, the patient was controlled. So sometimes there is a reason to remove as much as possible of the tumor just to improve the medical treatment, the medical control for the patients. So medial approach to the cavernous sinus, I already talked about that. You are inside the pituitary fossa. The tumor makes its own way to the cavernous sinus. There is a hole, like in this case, in the medial wall of the cavernous sinus. It's not very difficult. You follow the tumor. You can get inside the cavernous sinus. Like in this case, it was not a secreting, but a non-secreting pituitary adenoma, and we want to remove as much as possible of the tumor. You can work inside the cavernous sinus on both sides of the carotid. And in most of the case, pituitary adenoma are suckable tumor, and it's quite easy, and it's not so risky when you just have to follow the tumor. In this case, this tumor residue may be removed with more aggressive surgery. Now I will remove this part, but it's not a big deal because you will not cure the patients. And the goal of surgery was reached. You reduce the tumor, just keeping in place a small tumor remnant inside the cavernous sinus, non-secreting pituitary adenoma, perfect decompressions of the optic apparatus. So now you can wait or perform radiotherapy depending of the age of the histological analysis. Another case, it was a corticotroph adenoma in a colleague. It was a medical, it was a physician. So we can see here that's the microadenoma are inside the cavernous sinus. We open up the cavernous sinus. We just have to follow. It's the 6 nerve at the back. We remove the tumor and the patients were cured. So we can use the pituitary fossa to get inside the cavernous sinus. And following the tumor using the medial approach, it's not so risky, which is a little bit more risky, but which is, when I start, I don't believe that I need to do this kind of approach and this kind of medial wall removal of the cavernous sinus. But now with more and more training, it's very interesting in some specific case. Like in this one, acromegaly patient, it's not tumor invasive, invading the cavernous sinus. It's a grade 2, not a grade 3. But there is a close relationship, and in many cases, you will have a microscopic invasion of the medial wall of the cavernous sinus. So now, when you are trained enough, it's not so difficult like in this case. I will show you another video. You remove the tumor, you have the medial wall of the cavernous sinus, and in many cases, you will be able to remove the medial wall of the cavernous sinus. We have the carotid here. And it was the topic of a lecture. We were lucky to welcome in Lyon, in the last course in Lyon, the professor Nishioka, that talked a lot about the cavernous sinus in PITNET. And there was many debates about the cavernous sinus surgery. But I really believe that in many cases, in many patients and specific case, you can the patients can have benefits from more aggressive surgery, like in this case. Sorry for the quality of video. We have some concern about that. And you are here the pituitary fossa. You have the paraclival segment of the SCA. Here is the cavernous sinus. If you want to control the medial wall of the cavernous sinus, only with a medial approach, you have to remove the bone covering the anterior part of the cavernous sinus. Like in this case, I will be more fast. We remove the bone, and after you remove the pit net inside the cella with a piecemeal technique, it's not new. And now you can see here, I remove the bone inside covering the anterior part of the cavernous sinus. So I look, and I think that in this case, there is a slight invasion of the medial wall of the cavernous sinus. So I split a little bit the medial wall of the cavernous sinus. It's better to start at the inferior part. With a small spatula, you have the posterior intercavernous sinus. You split the dura, and it's not very complicated to split and to push away medially the medial wall of the cavernous sinus. You will see here the carotid with the sympathetic branches all around the carotid. So with a small spatula, you split, and after you will be able to cut the medial wall of the cavernous sinus. Here is the carotid with the sympathetic branches. Here is the pituitary gland. And the goal of that is to remove the medial wall of the cavernous sinus. There is no tumor inside the cavernous sinus, just in case of there is a microscopic invasion of the medial wall, trying to improve our results we can have for secreting pituitary adenoma, especially for acromegaly patients. So it's the medial approach. The medial approach you can get inside without a high risk of oculomotor nerve morbidity, because the oculomotor nerve are lateral to the carotid. Sometimes it's not so easy. Like in this case, it was exactly an acromegalic patient, the same case. But as soon as we start doing the dissection of the medial wall of the cavernous sinus, you can have this kind of issue, venous bleeding, and sometimes you will not be able to succeed to remove the medial wall. It's not possible in all cases. In sometimes it's very tricky, and when you start to have this kind of concern, stop doing that. You remove the tumor, and if there is some invasion of the medial wall of the cavernous sinus, you will see there is medical treatment on other also. So sometimes it's not so easy. But when you look at the results, and it's very interesting, there is the series of Diego, who published also a lot in pituitary surgery, in PITNET, in cavernous surgery. When you look at grade 3 invasive tumor, and some results are very impressive, like in the series in Nishioka, and with a little bit more than 50% of acromegaly patient that has been cured with a more aggressive surgery. And it's the same in the series of Diego. So it's very interesting. In some case, it seems that you will be able to improve your result in pituitary, secreting pituitary adenoma. So it's this kind of surgery is defendable for trained surgeon. It's not the same story when you start working lateral to the carotid. I mean, if you start dealing with a grade 4 tumor, because when you look at the result, the gross total removal is quite low, and the endocrinological remission is close to 0%. So it's more aggressive. And when you look at the series in the literature, when you start doing lateral approach for pit nets, you start to have some, very few, but some vascular injuries and oculomotor nerve palsy. So it's very risky in grade 4 in firm tumor and radius surgery. And you have to think that you need to be aggressive, and medial approach, rejection of the medial wall of the cavernous sinus, it's good for me. But for grade 4, it's very questionable and controversial because it's benign tumor and you have another optional additional treatment. I mean, you have for non-secreting, you have radiotherapy that work well. And for secreting adenoma, you have medical drugs and you have also modern radiotherapy. So my take-home message was should be cavernous sinus surgery, expert surgeon, tertiary center for pit nets. It seems to be very interesting for grade 3 Knopf's tumor, very controversial for grade 4. At least it's not in all cases you have to try this kind of approach. Not for recurrent or firm tumor, and it's a case-per-case discussion in a referral center. Thank you.
Thank you very much, Emmanuel, for this excellent overview. So you describe it very well, the transcranial approach for cavernous sinus, the endoscopic approach from the medial wall, from the lateral wall. And what I understand, the best indication is for functional pit net for 3A or 3B, not necessarily for grade B because there is other treatment options. I have two questions. The first one is, did you analyze the medial wall of the cavernous sinus when you take it out to see if there is a true invasion of this medial wall? This is my first question. And the second question, what is your advice for young pituitary surgeon when he or she want to do a transcavernous approach? Should we start only for 3A, 3B, only medial wall? What kind of advice could you done for this approach?
I'm not sure that very young pituitary surgeon should try. Because you are more and more comfortable and you can take a little bit more risk when you are a trained surgeon. I mean, it takes time for me to really get inside the cavernous sinus without risk and to remove the medial wall of the cavernous sinus. So, but the first step is when the tumor gets inside the cavernous sinus and make his own hole at the level of the medial wall of the cavernous sinus, so it's quite easy to follow the tumor. And in suckable tumor, working with two suction, I will not advise curette inside the cavernous sinus because I experienced, not me, but in my team, we experienced one ACA injury with curette. So I rather prefer, and I really advise people walking with two suction inside the cavernous sinus. You can walk all around the ACA. And the medial wall of the cavernous sinus, the removal, there is a very interesting description in the paper of Miranda. It's not so difficult, and you have to split the dura at the inferior part with a spatula and to lift up just to push away medially the medial wall of the cavernous sinus, and after with a scissor you can cut above and below. So it's, but it's I mean, for non-secreting pituitary adenoma is to reduce as much as possible of the tumor. Grade 3, it's interesting. But as soon as you have a grade 4 tumor, you will not cure the patient. So for non-secreting, you decrease the potential target for radiotherapy and not more. And for secreting, it seems to be, at least I think so, it seems to be interesting. You can follow the tumor inside the cavernous sinus in grade 3, and it seems to be interesting to remove the medial wall when the anatomical conditions are quite safe during the surgery, because in many cases you will have a microscopic invasion at the level of the medial walls. So it seems to be very interesting, and the paper of Nishioka, we talk a lot with him in the last course, are very impressive.
Thank you very much. Other questions from the speakers? Okay, let's go to the next talk with Hori. Hori, you are here?
Sure. I had a problem with the connection, but I hope it's now solved.
Good. Let's go for endonasal approach to the cavernous sinus.
Can you see it?
Yes.
Yes.
Moving?
Go ahead.
Good. Okay, hello, sir, everybody. Again, thanks for the kind invitation to this webinar. So I thought we have already anatomy done by Sebastian. That's why I did not focus so much on it. I just want to show some applications where we use the endoscopic technique to enter the cavernous sinus. Everybody knows the difference, endoscope, microscope. This is pretty obvious when you have small lesions in the cellular space. For example, a microadenoma, it can easily be done with a microscope. The endoscope has a little bit of magnification, illumination, but of course you can deal very well with this lesion. However, when the tumors are more laterally invading in the cavernous sinus, with the endoscope, you can see nicely around the corner, especially with angulated optics. With a microscope, you are lost. So you see, this is one patient where we have the microscopic view. You see the margins of the speculum here. Now we have the same case, and we remove the speculum and take a 0-degree endoscope. And you see, because of this wide angle of view, you have the whole orientation about the structures which are not seen with a microscope. So you see the clinoidal carotid here, cavernous carotid, clival carotid. You see the optic nerves, and that's why it gives so much safety that you can work within this area without the risk, or with a lower risk of injury, because everything is visible. To guide your approach to the carotid artery, the Vidian nerve has been described by the Pittsburgh group very nicely. If you have the Vidian nerve in your view, you can follow it and you have a nice view. It's very important to recognize that the Vidian nerve is going lateral to the carotid. So it's not safe when you drill medial of it, when you have to stay under it to avoid damage to the carotid in this area where the clival carotid goes to the petrosal carotid. But it's a good landmark. If you have this nerve, you found it nicely. So in the cavernous sinus, here, important structures. You know the only nerve which runs through the cavity is the abducens nerve and some sympathetic fibers coming to the carotid. All other nerves are in the lateral wall. And that's why when you work in the cavity, the abducens nerve is at risk. So we usually monitor the abducens nerve during these surgeries to be safe that we do not damage it. You see V2 is running here. It's the Vidian nerve, and then you have the supraorbital fissure with the other nerves. This is very important to recognize. Here again, you see abducens nerve, and you see the sympathetic fibers here. You see the clival carotid, cavernous carotid, and in the upper part, you see oculomotor nerve, V1, and the abducens nerve, and here's a V2. It is important when you want to look to these structures that you have an angulated optic, 30-degree, even better is 45-degree. You see here, this is a cavernous carotid, and you can look lateral to the lateral walls. You see here is the oculomotor nerve, and you can resect all these structures very nicely. Imaging is, of course, very important. We always make a CT scan to see the bony structures, the septum, the type of the turbinates we have, pneumatization of the sphenoid sinus and the septa. It's much more accurate than any navigation device. And then, of course, we make an MRI. You see here, this is a patient with a Cushing disease, and you see there is a complete infiltration of the cavernous sinus. Then the tumor going around the carotid in this part, lateral compartment, all compartments are involved. And then after surgery, you see here, this is a fat suppression MRI. You could see we could remove all the tumor around the carotid, but in the upper segment, extending more laterally, we have still some tumor, so we make a transcranial approach to get here a reduction of the tumor, and that is what we have finally. Of course, it's not a complete resection, but we could reduce the amount of cortisol very much, so that he is now good with the medical treatment with Signifor. Positioning is very important, so the body should be at least 30-degree up, especially if there are patients which are very obese, because the pressure on the cavernous sinus can be immensely high. It's surprising. Sometimes if you open up the cavernous sinus, you think you have opened the carotid because you have such a brisk bleeding. That's why very important to bring the body up. Then we turn the head to the other, to my side, and tilt it to the other side, so I can stand conveniently and look to the nostrils. Epinephrine is used for preparation of the mucosa, and the navigation can be used, but which is much more important, in my opinion, when you work in the cavernous sinus, is that you have a microvascular Doppler to locate exactly where's the carotid. So it's very helpful, and I would not dare to make extensive surgery in many cases when I do not have the microvascular Doppler. Instrumentation, of course, is important that you have angulated suctions to get around the corner. HD camera is a must. 4K you can use. I found the image quality of HD sometimes better because the color fidelity is more natural. You have a view to the chiasm of one patient with the tuberculum meningioma. You see the stalk here and the small superior hypophyseal artery, which are so important to preserve to have a good visual outcome. My manual dissection is, of course, important. It's the same like you do with microsurgery. So we have two hands and dissect the arachnoid with traction, counter-traction. When you have an intracavernous lesion, you are not sure where is the carotid. It's nice to drill the clivus, and then you see the carotid in the clival area. So you have a good orientation. You see here is the carotid. You know exactly where the carotid is expected. Then it's easy to dissect. Open the dura close to the carotid. There's no risk to damage it because you have it exposed. Then tumor can be resected easily. And then you see here, this is a carotid. The medial wall is destroyed by the tumor. You see, this is a remnant of the medial wall, like Emmanuel showed you. You can cut it and open it, and then you can resect the tumor around the carotid artery. And I use curettes always, but of course, you have to be careful because you might damage some vessels. But this is a nice approach. What is very important, if you have exposed the carotid artery, don't leave it open. You have to cover it. You can take fat, or like we did here in this case, we just put a little bit of collagen fleece around it and fix it with fibrin glue. It's very important when the carotid is not covered by dura and you leave it open, it can happen that you get a brisk bleeding, like Giorgio Frank has reported the first case where the carotid was rupturing 3 months after surgery, maybe or probably because of infection of the wall. So always cover it. So the approach can be combined with transclival, transstellar, transcavernous, transpterygoid approach. It depends where you go. If you have a good pneumatization of the lateral recess of the sphenoid sinus, you can see the optic nerve, and you see a V2 here running in the wall, lateral wall of the sphenoid sinus, and down you see the video nerve. So it depends from the pneumatization. And this is the carotid in the cavernous segment, clival segment, and here it goes to the petrous segment, and you can remove tumor lateral of the carotid with this angulated suction and angulated scope. And here again, you see the video nerve, which guides you to the junction of the clival carotid to the petrous carotid. And again, Doppler, very important to verify where you are. Scarabis reconstruction has to be considered. Most of the time, we make a nasoseptal flap on one side, and then we take on the other side the reverse flap to cover the septum where we took the nasoseptal flap from. And the advantage is that the revitalization is much faster. And the discomfort for the patient, decrease of quality of life is reduced this period. I can strongly recommend, since we do the reverse flap, really the patients are not so much suffering until the septum is re-epithelialized. So some examples: pituitary adenoma. This was a 30-year-old female with acromegaly. And she had the tumor, which also is invading to the cavernous sinus here on the left side. It's a large tumor. Fortunately, most of the time, the acromegaly tumors are very soft, easily suckable. So we go around and try to remove all of the tumor. To have a cure, that is always our aim in these hormone-active tumors. And then you see on this side, there is the perforation of the medial wall of the cavernous sinus. So we just follow the tumor. If it's soft, it's easily, you can suck it. You can also resect part of the wall when you think it's infiltrated. And, but here in this case, we just follow it. You see the tumor so soft. This is a carotid artery. We go around. This is a 40-degree endoscope, 45-degree endoscope. And then we resect the tumor, which is here adherent to the remnant of the pituitary gland. At the diaphragm, you see it's all tumor. Here is a small piece, again, adherent to the normal gland. And also with this we remove. And then we can go around again with suction. You see the diaphragma here coming, and all seems to be clear. So that's why I did not take all the wall out. And then we make the oral glucose tolerance test, and you see the growth hormone goes down to 0.4, which is per definition a cure of this disease. And this is 3 months after the surgery and MRI. There's another case with a hormone inactive tumor presenting with partial pituitary insufficiency, and it shows the tumor which goes here around the carotid. So grade 4 tumor. In this case, you see here again the carotid is completely encased. So again, we drill the clivus to see where is the carotid going into the cellular space. You see here's the carotid now exposed. Then we open the dura and we resect the tumor. First, we have a 0-degree endoscope, and then the tumor is suckable. And then it's easy to follow. It's the same what Emmanuel said. If the tumor is very fibrous, we would not chase the tumor at all expensive, especially if it's not an hormone active tumor, then it's not required. If you have a fibrous tumor, then it is an increased risk. See here the remnants of the medial wall of the cavernous sinus. We take scissors to open it more, and the tumor is soft, so it's easy to dissect. Here you see this is a carotid. So we open the medial wall and resect a little bit of it. And when it then starts to have severe hemorrhage from the cavernous sinus, then you know that the tumor is sufficiently resected. You have entered the tumor-free cavernous sinus, and then you can stop. So if it's a soft tumor, I always follow it and resect the tumor in the cavernous sinus. But if it's very fibrous, or you have on very old patients, 80 years, and it's a fibrous tumor, then I think it's not required. But you see here again, here comes the carotid in, verification with the Doppler. And then again, very important to cover it, that you don't have a surprise later on. So first day after surgery, now it's 3 years after surgery, she's now 5 years later. endocrinology improved, so she does not need any hormone replacement, no recurrence. This is a 36-year-old female, decrease of visual acuity, endocrinological okay, recurrent adenoma. You see the tumor goes far in the back in the cavernous sinus. It's not a big tumor. Here's a stalk pushed to the other side, but this is a problem. Tumor goes here in the cavernous sinus in the posterior compartment. It was a recurrent surgery, so we go in, orientation, we remove tumor in the frontal part, in the anterior part of the cavity. And then we go further deep, resect the tumor. And because of the nice magnification, you have a good overview, you know where you are. And you can follow the tumor in the back to get all the tumor out of this compartment. You see, carotid is here. And then we could follow it far in the back and have a good resection. Then MRI shows that we could remove all the tumor in this area, which was previously filled with tumor. This was an Indian type of tumor, also infiltrating on both sides, cavernous sinus. You see a huge tumor. So always the question is, coming from above or from below, we always start with an endonasal approach. But it's important when you don't get this piece of this tumor out and you stop, you will have a surprise in the night because you will have a hemorrhage into the remnant of the tumor, which might cause hydrocephalus and requests you to come in the night to make emergency things. So if you have a big piece of tumor remaining, then it would come immediately with a transcranial approach to get it out to avoid this apoplexy into the remnant of the tumor. You see, she had already hydrocephalus. We open it. First, we will go through the stellar space, optic nerve, resect the tumor. It was a very bloody tumor. Then the tumor is pulled out under the optic nerve, under the optic chiasm. This nodule could be taken out easily. And then you see when we look to the optic nerve, this is the optic nerve on the right side, and you see because of the pressure of the tumor against the optic nerve, it's almost cut by the pulsation of the anterior cerebral artery. You see only this part of the nerve is remaining, explaining why she's so bad. Then we found the diaphragma. So I don't resect the diaphragma study because on the upper surface there are vessels from the superior hypophyseal artery complex. So I just dissect it and we take only the tumor out. And we just left a little bit. You see here, this is oculomotor nerve, the SCA P1 here. And we just left a little bit of tumor behind the perforators of the PCOM. You see, this is a remnant what we left. Otherwise, we have really achieved a very good resection. It's decompression of the midbrain as well. And we put a little bit of fat into the skull-based defect, and then we put a nail septal flap for reconstruction. So this is a remnant. This other is just fat. And this is a later follow-up MRI showing the fat and the remnant. The remnant is not growing, so we just follow it. We don't add any radiation. This was a patient presenting with headache and a little bit abducens palsy. And you see here is a small tumor at the back of the clivus. And there's tumor also infiltrating a little bit to the cavernous sinus. So what we do here, we expose the carotid. So we unroof the carotid in the cavernous segment. Then we open the dura over the carotid because we know there is some tumor in front. Then we cut the dura, the retroclival dura, and then we get here is the meningioma, which can be nicely resected without any retraction when we could come from the transcranial retrosigmoid approach or Cavazzi approach. You see the tumor is the oculomotor nerve. And with a 45-degree endoscope or 70 endoscope, we can look behind the dura and can make sure that we removed here all of the tumor. Of course, you have to take care about the abducens nerve. That's why monitoring of the abducens nerve is mandatory. Here you see the basilar artery. So this part of the tumor could be nicely resected. She had a little bit weakness in abducens, but not much deterioration. And here you see our fat graft, which we put in the nasoseptal flap. But you see here, we went through the stellar space to this area. So then this was also an interesting case presenting with an abducens palsy. 53-year-old male, right abducens palsy, endocrinological intact. And then he has a nice, interesting lesion here, what you see in the cavernous sinus. So there is no filling of the venous channels. There is some non-enhancing lesion presenting here, and also here. So what is the best approach to go there? Is it a lateral approach? No, it's not, because there are all the nerves in the cavernous sinus. So that's why I decided to make an endonasal approach to open it lateral to the carotid to come into this lesion. So first we drill the bone overlying the carotid and the lateral space. So we unroof everything. And then, of course, microvascular Doppler, very important to verify, here's the carotid, so it's safe to open the cavernous sinus laterally. But of course, what you see, it starts immediately to bleed. What is the solution? We just inject flow seal. Flow seal is for these cavernous sinus surgeries, in my opinion, very important to get a good overview. And then you see with a small curette, we found the tumor. It looks to me like a chondrosarcoma, but the histological evaluation revealed an unusual mesenchymal tumor. Similar to chondrosarcoma, but they say it's not a typical chondrosarcoma, but it's also not a chordoma. So we remove tumor as much, have a good decompression, get the histology, and then we use flow seal for hemostasis. And you see all this lesion is taken out here. And now we do nothing, we just observe for follow-up. If the tumor will recur, probably we will send for proton beam radiation, or we make another surgery, depending how it looks. Features apex and cavernous sinus. This was a 60-year-old male, has an abducens palsy. He underwent a transcranial approach at another institution, but he could not do much because when they tried to approach the tumors, they had all the nerves in front. That's why, of course, again, we come endonasal, and we could go behind the petrous carotid, and then we can go laterally and can remove the tumor. You see here is the carotid. Petrous carotid tumor goes far laterally. So the approach was an endoscopic endonasal, transcellular, transcavernous, transpterygoid approach. Navigation was used. So we start to drill. This is the floor of a cellar. This is the clival carotid, which is completely unroofed with high-speed drill and with the kerosene. And then we were looking for the video nerve, which guides us to the junction between clival and petrous carotid. You see, here is the video nerve. So you just drill below and median, and it guides you to the carotid. So then we open the dura, and you see this is a typical gelatine-like tumor, which is easily suckable. Here's a normal pituitary gland, and now we are in the cavernous sinus. First, we have 0-degree endoscope, then we take a 45-degree endoscope, and you see how nicely you can look. It's the lateral wall of the cavernous sinus, and you can resect all the tumor under direct visualization. This is here the dorsum celli. This is the pituitary gland. Now we go further down and resect the tumor, which is lateral to the carotid. So here you see the petrous carotid, and with a curved suction, you can nicely remove all of this tumor. So there was no need to go lateral to the carotid. We just came medially, and then we have this curved suction. Again, video nerve, just to show you the anatomy. And you see we have a good resection. We left a little part of the tumor which is intradurally, and we just observed it. We did not put any radiation because it was a grade 2 tumor, not aggressive. And this is 2 years later. It's the same size, did not grow, and the patient died 4 years after surgery due to lung cancer. The final case I want to show is a cavernous sinus Meckel caves case, 40-year-old female, incidental finding with hearing loss. You see this huge tumor compressing the brainstem and going to the left cavernous sinus as well as to the Meckel's cave. So what is the best approach for this? Of course, we come here endonasal, we have a large space to enter. We always unroof the clival carotid to get more space. During dissection, then with a high-speed drill, we drill the floor of the cellar. And then we take out the posterior clinoids, which are infiltrated by the tumor. See, this is a typical appearance of a chordoma or chondrosarcoma. All this bone has to be taken. It's not only enough to suck the soft content, but all infiltrated bone, if possible, should be resected here. It's luxated behind the carotid. Taken out. And then you see here, now we go behind the carotid. This was a 0-degree endoscope, and now we switch to 45. And you see how nicely you can look behind the cavernous carotid and can make sure that you really resect all the tumor in this area. Again, here comes the dura. Again, some bony part of the tumor resected on the other side. And then with the curette, we have a good resection. Here again, the posterior clinoid on the right side was not so much infiltrated, but was clearly also involved in the tumors. That's why it is taken. And you see here the dura to the brainstem is open, but I don't resect because you will not get anything, all the tumor cells out in these cases because the tumor grows along the nerves. So I left it, and then we put fat and we put the nasoseptal flap. This is a fat filled photon beam radiation. This is the result, no tumor remnant visible, and she's doing well. So finally, I want to invite you to the World Congress of Neuroendoscopy, which will take place in Graz in Austria, and we will discuss much more of these interesting cases. So thank you for your attention.
Thank you very much, Harry, for these impressive cases. It's not only for PITNET. We saw many cases like chordoma, chondrosarcoma, and for sure this kind of surgery is for dedicated endoscopic skull-based surgeon, not only for pituitary surgeons. So it's very important to have very good skills to do this kind of surgery. We have some question from the audience, like do you enter from the opposite nostril when operating such tumor? When you want to go to the cavernous sinus, do you use the opposite nostril?
Usually, I prefer the binostril approach because I like it more when I have not this coaxial working, but more this working what I have in microsurgery and transcranial surgery. That's why usually I come from both sides, and then I'm the variable. Sometimes I come with a scope from this side and from this side. So it depends. When I make a one nostril approach, which also happens when the nostrils are very asymmetric, one septum deviation, or when I just take a small lesion like this cavernous sinus lesion, then I come from one side. And then it's depending on the size of the sphenoid sinus. If it's very narrow, then it's better you come from the contralateral side. But if it's wide with a large recess on the other side, then I come from the same side. So it's a very individual decision based on the findings what we have.
Yeah, thank you very much. The last comment, really, we discussed it many years ago, and now when I do the nasoseptal flap and I use the reverse flap, I discussed it with you. It's very, really, it's very useful for the patient and the quality of life. I didn't do a real study on that, but my impression is with the reverse flap, the quality of life is better for this kind of extensive endoscopic approach.
Yes, I completely agree because the revitalization is much faster.
Yeah. Thank you, Ori. Now we will go to the last topic with Diego Mazatanta.
Good evenings. Thank you for the invitation. I would like to share my presentation. Okay. Sorry. Do you see well my presentation?
Yes.
Okay. After the previous colleagues and talks, for me, it's very easy to stress a very simple concept. We understand very well there are two main areas, the middle compartment of cavernous sinus and the lateral compartment. The middle compartment is located between the pituitary gland and the ICA. The lateral compartment is between the ICA and the lateral wall of cavernous sinus. To work inside the medial compartment, it's enough to perform a midline standard transsphenoid endoscopic approach. Conversely, if you want to work laterally to carotid artery, you have to expand the approach, removing the ethmoid and the pterygoid to work more laterally to the carotid, internal carotid artery. But don't forget, in our experience, that 80% of the tumor invading cavernous sinus was operated using the only midline transsphenoidal approach. It's not always necessary to perform an expanded approach to work inside the cavernous sinus. The first question is when? Where are the best tumor can you treat using the endoscopic approach? Soft tumor, preferably extradural. Pituitary adenoma, chordomas, and chondrosarcoma are the best tumor you can treat using this type of approach and this technique. Conversely, the malignant tumor, other infiltrating tumors such as meningioma, will be more dangerous to manage the internal carotid artery during the tumor removal of this type of tumor. The best question is, why work in cavernous sinus? There are four major reasons. First of all, detection of invasion. The possibility of the endocrinological cure. Professor Janot showed the low rate of cure, endocrinological cure, but it's not absolutely 0%. The possibility exists. Relieve the compression of the cranial nerve. Relieve the cranial nerve palsy is another best topic to work inside in the cavernous sinus. And don't forget that the debulking increases the effectiveness of medical and radiation therapy. If you work inside the cavernous sinus, you have to understand deeply. You work in the multidisciplinary teams with endocrinologists, radiotherapists, and radiosurgeons. First of all, detection of invasion. It's very clear this is the similar tumor with a very close relationship with the cavernous sinus. In the first cases, you can see with the endoscopic inspection, the medial wall is completely, there are no perforation, it is only compression of the tumor. Conversely, in the same similar tumor, you can see a little hole in the medial wall of cavernous sinus. It is most important in case of a secondary pituitary adenoma, removing it to try to allow the endocrinological cure. So similar neuroradiological workup, completely different surgical inspection. But what is important, the detection? We use the trial classification, the anatomical classification, and we understood, publishing also our experience, that the detect the invasion could be a main prognostic factor in the pituitary tumor natural history. What does it mean? If you're in front of a patient affected by infiltrating pituitary adenomas, infiltrating cavernous sinus, is completely different to the natural history of the tumor not infiltrating the cavernous sinus. And the detection using the endoscopic approach is the most important to achieve this information. But don't forget, the 80% it's enough, the midline transsphenoidal approach. The second point is possibility of endocrinological cure. This is the case of CNOSP4 of ACTH adenoma, Cushing disease. So we have to try to cure this patient. In this schema, you can see the pattern of invasion in case of Cavernous classification grade 4. And the most important, to try to allow best results. You are in the nasal fossa. The first step is cutting of a middle turbinate to allow space in the transethmoidal root. The nasal septum is more lateral in your surgical field. You move more laterally during also in the nasal phase. You have to remove wall ethmoidal box to control the lateral part of the sphenoidal sinus. This is a contralateral approach. We use always the bimanual approach. We enlarge the sphenoidal sinus, and this is your wall, posterior wall of a sphenoidal sinus. Don't forget, the anatomical midline is there. Conversely, the surgical midline is in front of carotid artery. For this surgery, it's mandatory to use the neuronavigation and also the microprobe Doppler showed before Schroeder. This is the bulging of tumor invading the dura madre of lateral wall cavernous sinus. We check the correct position with the microprobe Doppler, very effective, very cheap, and start the tumor removal, such as you have seen before. The tumor removal starts in the midline part in the tracellar approach, and after we move laterally. After checking the carotid artery, we move laterally and we open the medial wall of cavernous sinus, moving laterally to the cavernous, to the internal carotid artery. This is the carotid artery. This is the medial wall of cavernous sinus. You can enter with curette, dissecting the medial wall of cavernous sinus, and you gain access anteriorly and posteriorly to carotid artery. Obviously, the consistence of tumor is crucial for this kind of surgery. You can see the medial wall of cavernous sinus. This is the carotid, and you can move using two different scoring. At the hand, when you achieve a gross total near radical removal, you can perform inspection with the angle instrumentation and with the angle telescope. You can see the naked carotid artery and the third cranial nerve and sixth cranial nerve. As before affirmed, Schroeder is mandatory to cover with the mucoperiosteum and fat the internal carotid artery. Don't leave the internal carotid artery to hair. This is the MRI post-op, but the most important in second pituitary adenoma is that the level of cortisol post-operative, 12. The patient in this case was cured. Another case, the patient affected by PRL circuiting pituitary adenoma resistant to cabergoline. Obviously, there are no medical therapy. There are two only options, surgery and radiosurgery. We start with expanded approach because if you are in front of Cavernous classification grade 4, we move, we open medially. You are in the left side, obviously. This is the dura madre covering the internal carotid artery. We move to medial to lateral using the perforation of the tumor of the medial wall of cavernous sinus. And after, this is the position of the carotid artery, checking with the neuronavigation microdoppler. We open lateral to internal carotid artery, the dura madre, and we create the second channel, second surgical channel, medial and lateral, working in both sides of the internal carotid artery. This is the surgical post-op, but this is the best results. 7 nanograms. The patient was cured without using the radiosurgery. Obviously, the endocrinological results are not so effective. We have to be honest. The remission and the gross total was achieved in very few cases, and Professor Genot showed there are big difference between the grade 3B and 4 of not classification. In the other localizations, such as 3A and 2, the endoscopy could be more effective also in secondary pituitary adenoma. The third indication to work in the cavernous sinus is relieve the compression of the cranial nerve palsy. You can see a grade 4 of cavernous sinus. In this schema, you can see the 3 different patterns of invasion. The first one is the tumor push laterally the internal carotid artery. The second one could be more dangerous. The tumor developing in the lateral compartment push medially the carotid artery. In this case, could be more difficult, more dangerous than in the other case. In case of grade 4, obviously, there is a total encasement of carotid artery. We start removing the central part. We move laterally, opening also the lateral corridor. In this case, you can see you work your midline of your surgical field is in front of internal carotid artery. You have to manage. This is the medial corridor. Don't forget the cranial nerves run inside the lateral wall of a cavernous sinus. The only 6 cranial nerves run free below the position of the internal carotid artery. This was the results, with preserving, obviously, the pituitary and its stalk. The compression is the most important. This is well known since 1988. The compression, the surgical compression, is the best treatment to try to relieve the cranial nerve palsy. In our experience, remission improvement are the large percentage of success. Obviously, there is always a percentage of risk to use this type of approach. The second class of tumor with the endoscopic endonasal approach is the best choice to treat is in the case of chordomas. This is a paper, is a Italian multicentric study. In this study, we divided 2 different areas, 1998 to 2008, and 2009 to 2018. The endoscopic endonasal approach was the best approach in the new era, in the endoscopic area. And the results of gross total removal were also significant. Why to use the endoscope? Why to use the cavernous sinus surgery? Because the Kaplan-Meier showed clearly that the gross total removal plus proton beam radiotherapy is the best choice of a multimodal strategy of treatment in skull-based chordomas with peak significance inferior to 0.001. So it is most important to achieve the gross total removal. In this case, if you have to work inside the cavernous sinus to try to remove gross totally this type of tumor. And this was the results. Also for the chordosarcoma, this is a large chordosarcoma invading cavernous sinus and entering posterior fossa, displacing laterally the carotid artery. This is the early MRI postoperative. This was the MRI after 1 year, and this is the out-of-office control after 4 years of follow-up. The bulking to increase effectiveness of the other treatments is another pillar of this type of surgery. It is useful to radiation oncologists and endocrinologists if you make a question, or the radiation oncologist and the endocrinologist affirm that the bulking, the surgical debulking is the most important to achieve the best results in case of to use the radiotherapy after or the medical therapy where indicated. You can see this is our experience to plan a gross total aggressive surgery in cavernous sinus surgery could be useful for the endocrinologist, for the pituitary tumors, and the radiation oncology in case of chordomas and chondrosarcomas. Don't forget this. It's always possible, always no. This is the GH pituitary adenoma. You can see we have to remove the cellular compartment. We check the carotid artery and we try to enter in the lateral corridor of cavernous sinus. We enlarge with this sector. After the dura madre opening, we try to enter with curette, but the consistency was completely different. Very firm turo, elastic, and we abandon the surgery and we address to the treated remnant to use the sandostatin or radiotherapy. In case of meningioma, this is a complex intra-extracranial tumor. The patient complains intracranial hypertension. We choose to use a multi-stage strategy. First of all, through craniotomy, we remove the intracranial compartment to relieve the hypertension. In the second step, using the endoscopic approach, transmaxillary, transpterygoid approach, we remove the second part of extradural compartment of part of the meningioma. Remains the cavernous sinus located inside the cavernous sinus. In our experience, in our opinion, we believe that the best approach for this type of tumor located in cavernous sinus is radiosurgery. We don't touch this type of tumor using endoscopic approach. Our series is more than 600 cases. The large part, obviously, were pituitary adenomas, and there are a very a good percentage of chordomas and chondrosarcomas. Complication with correct indication, with a good experience, knowledge of the endoscopic technique, we published and observed in pituitary adenomas only one case of ICA injury, 0.2% of complication of this type of surgery. Conversely, in chordomas, in the overall of the two different areas, we observed 2 cases of internal carotid artery, 2.5%. In conclusion, remembering our mentor, Giorgio Frank, a real pioneer in this type of surgery, he believed immediately to use the endoscope to move to medial to lateral cavernous sinus. If you use the correct indication with a good skill, with a good learning tool, you can achieve a good results and permit a multimodal strategy, a good quality of life for your patients. Thank you for your attention.
Thank you, Diego, for this excellent presentation, clear, and its overview from pitnet to chordoma. Roy, you are here?
Yes, yes, absolutely.
Okay.
Yeah. So I just got a message from Sebastian that he's very busy at the EANS conference, and he sends his apologies and regards to all. Pablo has just joined us. Pablo, would you like to say a few words?
Yes, that I'm super sorry that we had an emergency posterior fossa bleeding, and I was very lucky to watch last Diego's slides, and I really enjoyed that. So I'm sorry, and thank you for this invitation.
Okay, any further comments, Henry or Diego?
No, I think it was clearly shown that the endoscope has so many advantages when entering the cavernous sinus, and that it's very important that you have the right equipment. And microvascular Doppler, I think, is the best to really keep your orientation. Navigation is not so accurate enough. It is okay for the approach, but you know, a few millimeters are too much in this region. So with a Doppler, you can really precisely say where's the carotid, and you can open and you feel more confident. When you don't have it, I think it's a little bit risky. And of course, there's always a debate, how aggressive should we be? We have radiosurgery for cavernous sinus lesions, and we have also medical treatment for some of these tumors. But I think in the endocrine active tumors, we always try to get a gross total resection to have a cure. And if the tumor is soft, it's easily achievable in many cases. If you have, for example, a prolactinoma pre-treated with dopamine agonists and it's very fibrous, and then of course you have to be balanced. It should be aggressive or should you be not. And then I think sometimes better you stop.
Yeah, the consistent is crucial when you do transcavernous approach. And I'm very happy to see 2 slides about complication, because we have don't to forget the complication and vascular complications. It will be dramatic in this kind of approach. And we should also have a back plan when we do this kind of surgery with neuroradiologist, interventional neuroradiologist. It's very important. It's not just an adventure to go to the cavernous sinus.
This surgery is important to perform in tertiary center, because the role of a neuroradiologist is very crucial in case of damage of internal carotid artery. And also the experience. I agree completely with Henry. Understood immediately if the tumor is soft or not softer. It's the most important to carry on the procedure. In case of you are any doubt, it's enough one doubt. It's the best choice is to stop the procedure, because in case of film tumor, it's really, really dangerous to perform this type of surgery. The consistency is crucial. It's, and also it's our job for the all different approach of different techniques. There are different indication. It's not, there are not only one tools for whole surgery in neurosurgery. So we believe in this type of surgery, but very few selected indication. In case of the other tumor, we choose the other strategies.
Okay.
I'm very happy to see the interest that the medial wall of cavernous sinus is gaining worldwide. And in fact, for this year's EANS meeting, there were multiple papers on that. We have selected at least 3 of them to be presented internationally. So there are people in all parts of the world now focusing on the medial wall of the cavernous sinus. And we are hoping to see more and more literature come out to see what the true value of resecting the medial wall is and what are the true rate of complications involved in it. So there's a lot of interest in this field, and I'm happy to see that there is close to 200 participants for this particular webinar. So I thank you, all of you who presented. Unfortunately, we couldn't have Pierre and Sebastien. Mahmoud, would you like to close the session?
Yeah, thank you very much for everyone. It was a great session. Thank you, Roy, to organize this specific session. Thank you.
Thank you. Bye-bye.
Thank you so much.
Bye-bye.
Wish you a nice
Thank you
evening.
so much.
Bye-bye.
Good evenings. Ciao.
Bye-bye.